But without further ado, I will introduce Roberta Nole. She is the owner of Stride Custom Foot Orthotic Labs and inventor of the patented quadristep foot orthotic system. She's a physical therapist and certified foot orthotist and has a master's degree in sports medicine and biomechanics. Foot typing algorithm that identifies 24 variations of the normal human foot, and she teaches classes based on the original technology. She is a member of all kinds of organizations, including the American College of Foot and Ankle Pediatrics, better known as ACFAP. So I am going to let her take it away.
Thank you, Anne. That's a very nice introduction. Thank you very much. So yeah, I'm Roberta. I don't know who's attending and if I've met you or not, or if you've heard me speak or Lewis speak. So some of the introductory stuff, I'm going to do some quick overview of some of the basic premises of our foot typing system, so that any newcomers are not lost in the weeds and can kind of, get brought up to speed. But we have extensive recorded webinars that we can get you access to. If you like biomechanics and you want to become a biomechanical expert, I'm going to give you some ways to become that. If you're not confident in your biomechanics, our job is to make biomechanics easy. So tonight we're going to be talking about two primary foot types in our quadricep system. You'll see the little colorful chart in the middle that color codes and letter codes 6 different groups of feet, A through F, and A is the yellow and C is the blue groups, and those are the ones we're going to focus on because those are the feet with the fullest arches. We're going to see there's a fundamental difference, a big difference in the way a subtle cavus foot may walk versus a really high cavus foot structure. So we're going to be differentiating between an A and a C, so you understand that not all cavus foot types, just like not all flat foot types, should be treated the same. There are different orthotic prescriptions and features that you want to use for each foot group. So starting with pediatrics, you may have heard my associate, Dr. DeCaro, speak on pediatric foot management and the etiology of the adult foot type. So really quickly, 1-minute review. We know kids are born with flat feet. That's what our pediatricians tell us. It's normal for kids to have flat feet. But really, that should be taken as an age-specific parameter, not just it's not like you're flat-footed one day and then all of a sudden you have an arch. It's a process. So under the age of 5, it's quite normal for feet to be pronated and everted. Little babies have those cute little squishy pes planus flexible flat feet. And so Val Massey was an author who came up with a nice mathematical model that says 7 minus your age is how much valgus should be normal for a particular child. So if I'm looking at this picture and it's a 1-year-old, 7 minus 1 is 6. So it's not bad if you're looking at this picture and this is a 1-year-old to see heels rolling out 6 or 7 degrees, flat arches, squishy feet. But if I'm looking at this same picture and that child happens to be 5 years old, Val Massey's rule of 7 is 7 minus your age is how much valgus you should have. So at 5, 7 minus 5 is 2. So this child should only be everted 2 degrees, and that's too much. So as we flash forward to the 6 to 8 age group, once we get to the age 7, 7 minus 7 is 0. The heel should be vertical to the ground. We should start to see an arch. As we move into the preteen years, the heels are starting to turn inwards relative to the ground, because let's say we're looking at a 12-year-old, 7 minus 12 is -5. So by the time you're 12, your heel should be inverted at least 4 or 5 degrees, which mirrors a nice healthy adult foot that we see right here on the right. If your heel's inverted 4 or 5 degrees in standing, and mind you, this isn't subtalar neutral, this is relaxed calcaneal stance. When you're fully pronated in a standing position, you should have a nice normal arch if your heel is inverted 4 or 5 degrees. Now, some kids are going to overshoot that, about 10 to 12% of the adult population. And let me back up and say, in the foot world, you have an adult foot by the time you're 12 to 13 years old. So by the time you reach your adult foot type at 12 to 13 years of age, you should have a moderately inverted heel, but some kids are going to overshoot that and their heels are going to become more significantly inverted to the ground. And 10 to 12% of the population will end up with a cavus or high arch foot type. Now, the foot types that I'm going to be focusing on tonight are the ones that we predominantly see in our practices, which are neurotypical cavus foot types. There are neurological reasons for foot types like Charcot-Marie-Tooth, things like that, cerebral palsy. A lot of those cases are not going to be orthotically managed. They're going to require bracing and possible surgical procedures. So we're going to stick with the biomechanical cases for this evening. In my original foot typing patent, I've identified 24 different types of normal congenital foot types, and they fall into 6 color-coded foot groups. The A quad, the yellow group, is the highest arch of all, and that's up in the upper left-hand corner of the chart. And the C quad is more of a normal to sometimes subtly cavus foot. And then the red group is moderately pronated in the arch. These patients will still have an arch, but they'll be a little bit lower than you'd like to see. And then purple, green, and orange go flat, flatter, and flattest. So when we're looking at feet, these 4 groups are our pronators, and the A and the C are more neutral to supinated foot types. And those are the 2 cases we're reviewing this evening. Every foot has a story. Okay, so all 6 of these, and this is what we call our quadristep chart. And if any of you like this and you want to hear more about it, we actually have these posters available. They're really nice posters to hang in your treatment room. I like to think of them as crib notes, so you can go and look at the chart while you have the patient in the room. It reminds you of everything you need to know about each of these 6 foot groups without having to kind of memorize it. Once you start doing this foot typing process, it becomes really second nature. But in the beginning, sometimes it's hard to remember everything, and everything's right here for you. So the A and the C group are the 2 foot types that we're going to focus on, because those are a normal or quote unquote normal looking arch to high arch foot types. And another time I can talk to you about what I think normal is. So really quickly, just a quick quick view of the way people with fuller arches walk. You can see there's quite a bit of a difference. C quads walk like a duck with 1 foot pointing east and 1 foot pointing west. A quads walk like they're on a tightrope, 1 foot in front of the other. By the time we're done today, you're going to know why. It's pretty obvious once you start to think about how those feet are coupled together. But keep in mind that I'm going to go backwards 1 slide, or 2 slides, I lied. To here, it's not like in the foot typing algorithm, it's not like you're an A or a C or an E. It's kind of like a sliding rule. So you could be a high A or a low A, or a high C or a low C, so your quad could be between an A and a C. It could be between a C and a D. And sometimes it gets really confusing down here, where you can have attributes of all 4 foot types. But it doesn't have to be complicated. There are some simple ways to kind of work out what to do when you hit those crossroads. And I'm hoping that I can shed some light on that for you. So I like to give a little teaser to make sure some of you don't fall asleep on me tonight, or walk away, or maybe have a glass of wine and then go get the rest of the bottle. Let's stick here for a little bit of time and talk about a special offer I'm going to give to you at the end of the meeting for those of you who stick with me tonight, because I love teaching and I'm hoping that you enjoy some of this. So I have a 4-step foot typing model, and that shows you how to determine the foot type. But really, you're going to see you only need step 1 and step 2 to really know what color group you're in. So it is pretty easy. If you want to learn more about or see a visual of this foot typing step, you can email me and ask me to send you a link to the foot typing app on our website. But in step 1, we're going to do the arch assessment. Now, I like to also say, don't put all your eggs in the arch basket, because looking at arch height alone isn't going to tell you what you need to know about the foot. That's why I say the runner's world wet test is all wet, because you can't just look at arch height. There's more to a foot than that, but it is a good place to start. So making this really simple, if you have a patient standing in front of you, barefoot, and they stand and they march in place just a few steps, and you're looking at them from the front, and you see they have an arch, they're either an A or a C. You know, our A's and C's, a C will have kind of what we consider a normal looking arch, but we can also veer into those feet that have maybe too much of an arch. So if the answer is, yep, this person has a pretty decent looking arch, if not a little high, then you can eliminate options B, D, F, and E. So that's the name of the foot typing 4-step process, is a process of elimination. So don't look at a foot and go, oh my goodness, is that, maybe that's a D. Don't skip the steps. Ask yourself first, does this person have a medium to high arch? And if the answer is yes, you know you're in the A or C group. If the answer is no, you have 4 choices. The next step is we're going to look at that same person from the back. We're going to walk around behind them. Also, I like to say I don't make people stand with their knees pointing straight forward in the frontal plane. I want them to stand in their preferred standing posture. So let them march in place and stand however they feel comfortable, because that's a clue. If they stand toe out or if they stand pigeon toe, that's all clues. So once you see they're standing in a relaxed position, you go behind them, you're going to look at toe sign. Toe sign is how many toes do you see on each side of the leg? If you're in the middle row, then the middle row represents a neutral forefoot. So this is going back to the theoretical Rudian theory. If I was to put the patient in a prone position, subtalar neutral, look at the plane of their forefoot relative to the bisection of the heel. If their forefoot is perpendicular to the heel, that's a neutral forefoot. If the forefoot is inverted on the heel, that's a forefoot varus. And if the forefoot is everted or invalgus relative to the rear foot, then we call that a forefoot valgus. So the A quad, the feet in the middle row are going to have what we call a neutral toe sign. Because if you have a neutral forefoot, when you come down to the ground, you end up loading the forefoot evenly across the whole plane of the forefoot. If you're on the bottom row, you're going to have a forefoot varus, and when your forefoot comes down to the ground, you're going to load on the outside of the foot. And as you load on the outsides of your feet, and then you have this inverted forefoot, you have to pronate through propulsion, which draws your toes away from the midline of the body into what we call too many toes. So a neutral forefoot loads and splays evenly, and we see a neutral toe sign where I see toes equally on both sides of the leg. But if you have a forefoot varus and you come down to the ground, strike on the outsides of your feet, pronate through propulsion, your feet draw into abduction, and you see too many toes laterally, and you can no longer see the big toe medially. Now, here's an interesting thing. Forefoot valguses that are in the top row, we don't really think about these too much. They're kind of the overlooked child, you know. But the forefoot valgus, when it hits the ground, it hits the opposite way. It loads on the medial side of the foot first, and then the toes are drawn inward into adduction, and we end up with what we call a peekaboo toe or a peekaboo hallux, where I see too much of the big toe medially, and I'm starting to lose sight of the lesser toes laterally. So really, there it is. You know, you see 2 steps. We're looking at arch height and toe sign. And from that, this is what I call the Mr. Miyagi moment, where I teach you how to wax my car and paint my fence and do all those chores. And you say, hey, Roberta, when am I going to learn how to foot type? Well, you're the Karate Kid and you already know how to foot type. So here's what I'm going to tell you. Show me wax on, show me wax off. If I say, patient walks into your room and they have a pronating arch, then we know they're one of these 4 colors. And we can eliminate the A and the C, because A's and the C's, they're not pronators. They have fuller arches. So if I'm looking at a pronator and they have a neutral toe sign, that's a D quad. If I'm looking at my next patient and they come in and they have kind of a normal arch, a nice full arch and a neutral toe sign, that's going to be a C quad. Next patient might have a pronated arch and a peekaboo toe, where I see too much of the hallux. That's your B quad. And then our A quad is a cavus arch, really high arch foot and a peekaboo toe. And E's and F's are really pronated. They both have too many toe signs. They're both pronators. So the biggest way you can differentiate an E from the F is based on severity. An F quad is going to have a valgus heel alignment, significant strain on the posterior tib, while the E's are going to have a moderate strain and too many toe sign, but their heel is going to be maybe slightly inverted or close to vertical. It's not really going to go into valgus. Now, I know I went through that pretty quick, but I have recorded a webinar on that. So if you're interested, email me and I'll get you a link to it. Step 3 is looking at gait. And I am going to review 2 of the 6 tonight. I'm going to review the C quad and the A quad, and we're going to differentially assess gait of these 2 feet. And you're going to see how easy this can be once there's only six gait patterns. Anybody can learn those. So you're going to see, once you've seen one C quad, you've seen them all. So it'll be easy to remember once you start to see the repetition and the gait patterns. The next 4th step is looking at calluses. Each foot type has a distinct callus pattern across the forefoot. I don't put a lot of emphasis on heel callusing because some people just have lots of heel callusing, but most people are going to have a very distinct callus pattern. So we're going to see the A quad has a callus on the 1st and the 5th metatarsal head, while the C quad, which is also can be a normal to subtly cavus foot, they have hardly any, they have very kind of baby soft skin under the ball of their big toe, and they have a big callus instead on the hallux. So we're going to see why. And then all the other foot types have their own callus patterns because of their unique foot shape and the unique way that they walk as well. On top of that, each foot type is going to have a particular set of symptoms. So you can break out your crystal ball and say, oh, you have a C quad. You probably have hip pain and back pain. And people are going to go, how did you know that? Because it's not rocket science. It's the way that you walk. The way that you walk causes hip and back pain. Or in the A quad, it causes knee recurvatum, it causes sesamoiditis. So all these things become very predictable once you understand the biomagic. It's not biomagic, it's biomechanics, and it's very easy. So now we're going to look at, go back to the beginning. When we looked at that step 1. Step 1, we were saying, what's the arch height? The arch height is controlled by your heel alignment in its maximally pronated position. So subtalar neutral, don't worry about it. Nobody functions in or near their subtalar neutral. So when a patient stands and they put all their weight on their foot, your foot's going to immediately, very quickly assume its most pronated position, which is dictated by gravity and what your heel can or can't do. If you can pronate, you will pronate. And what you see in this video on the right here is somebody who can pronate, their arches just go as far as the ground will allow them to. The heels roll into valgus, the arch collapses downward, the foot splays out, the posterior tib and plantar fascia get overstretched, the ground reaction forces are jamming up the lateral column of the foot, the first ray is getting jammed up medially, and that's your really hyperpronated foot. The A quad and the C quad, they don't have that scenario. They have a foot that has a difficulty pronating. So let's watch this video here. This is a really interesting and fun foot type to pick on because I like to tell these people, hey, I'll give you $100 if you can put your arches on the ground. And you'll see this kid right here, he was a teenager. He really wanted my $100, but he could not, as hard as he tried, put his arches on the ground. Let's pause this video. Here's supination. Supination, no problem. But pronation, oops, sorry, hit the wrong button there. Pronation, when he pronates, he's lifting the entire lateral aspect of his foot off the ground. But as hard as he tries, he cannot get that arch to drop. It'll start to kind of shift over. I call that shelving. Shelving can happen at the midfoot. It could also happen at the ankle. And what shelving is acquired breakdown, pathological motion acquired at the mid-tarsal joint or pathological motion acquired at the ankle joint when the subtalar joint can't do its initial goal, which is to pronate and absorb shock. So A quads and many C quads, they can't pronate adequately. And so because of that restricted pronation, force is transmitted up the axial skeletal system into the shin, into the knee, into the hip, and the sacrum, and the back. And people who have A and C quads will often have posture pain, hip pain, knee pain, back pain. And so we got to think of postural symptoms. Not everybody that you treat with foot orthotics has foot pain. People who have foot pain obviously need foot orthotics, but there are many, many people who have hip pain that need orthotics. And how many people are knocking on your door going, hey, doc, my hip is killing me. I need orthotics. They don't know that. You need to educate your patients and tell them that, you know, foot orthotics are not just good for foot pain. They help a lot of ailments. So again, really quickly, we're going to cover the A quad and the C quad. And the difference is the C quad, which we're going to start with, because that's the base deformity, is a kind of a normal looking arch, or maybe sometimes subtly cavus. And as age goes on, maybe subtly pronated. But they have a stronger arch than an average person. And they have a neutral forefoot because they're in the middle row. While the A quad also is in the same column. It's on the left side of the chart, so we know they're kind of supinated in the heel, but the A quads have a forefoot valgus. So let's get on with, and no further ado, we'll get to it and start looking at the first foot type, which is the C quad. Now we have nicknames for all 6 of the different foot groups, and if you've heard me lecture or Lewis lecture, you know them, but this is what we fondly call the John Wayne walker. The C quad walks with 1 foot going east and 1 foot going west. And so they walk like they're a cowboy that just got off the saddle of the horse with their gunslinging. So feet pointed outward. Now, why do they point outward? That's what we're going to, kind of investigate today. But keep in mind where they are in this chart. They're on the left column of the chart. The left column of the chart are the lesser of the pronators. They have an inverted heel to floor alignment and a neutral forefoot. Now, we're going to get into this a little deeper in just a few minutes, but when I say the heel's inverted, you're going to say, how inverted? Well, if it's 4 or 5 degrees inverted, we mentioned earlier, 4 or 5 is a good thing. That's where we like to see heels inverted. But some C's can be inverted 6 degrees, 7 degrees, 8 degrees, 9 degrees. I've seen as high as 13 to 14 degrees. Anybody higher than that probably needs an AFO. But if you see a heel that's really inverted, you're going to notice that the whole medial column of the foot starts to get elevated from the ground. When you can do this, place your feet on the floor right in front of your table, wherever you're sitting, start to supinate your feet. And as soon as you supinate your feet to a certain extent, the whole medial column of the foot elevates off the ground. And now you're kind of walking around on the outsides of your feet. So we're going to see, what does this foot type have to do to get weight back down on the medial column of the foot? That's the question. So let's watch a video of a C quad in gait. Now, remember, C quads are supinators at the rear foot. They don't pronate. So if you can't pronate, you can't absorb shock. So the first thing I want you to do is look at the deck of the treadmill. Look down at the deck of the treadmill, and you'll see the deck of the treadmill bouncing up and down. Because when they impact the ground, there's no pronation, there's no shock attenuation. So where's all that shock going? Up. It's going up into their shin, into their knee, into their hip, into their back, into their pelvis, sometimes even the neck and the thoracic area. So let's go ahead and stop this video at heel strike. We'll go down to heel strike of the left foot. Now, this is an older video. I think I might have taken this with one of my first cameras. Maybe it was a 1.7 megapixel, so it's pretty grainy, but it doesn't matter. You don't need a sophisticated gait analysis system. You can use your phone. That's all you need. When the heel comes down to the ground, because the heel is supinated or inverted relative to the floor, initial contact is on the lateral heel and very, very quickly at foot flat on the lateral column of the foot. So what do you think you're going to see there? When you take that foot later and you're doing your non-weight bearing examination, you're going to see heavy keratotic skin. It may not be callus, but it's going to be that yellowish, thick skin along the whole lateral border of the fifth ray. Sorry. When that foot comes down to the ground, you're going to see, if you had your x-ray goggles on, you'd see this heel is still inverted relative to the ground. Pay attention. If you look at, we know underneath our calcaneus, we all have this, excuse me, kind of viscous infracalcaneal fat pad. If you perpetually load the lateral column of your heel, that fat pad migrates medially, and it kind of fills in the void underneath the medial calcaneal tubercle. So anybody can get plantar fasciitis, but it's interesting to point out that C-quads, they usually don't get plantar fasciitis until their 40s or 50s, when their infracalcaneal fat pad starts to wear away and gravity starts to take over. And everything sags as we get older, so the arches start to come down, that fat pad erodes away, and instead of having this normal kind of self-posted rear foot, that arch starts to come down. So we see this heavy lateral weight bearing on the outer side of the foot, and then as we go into mid stance, nothing much happens. The heel stays inverted. So we can see there's a constant kind of tug on the lateral Achilles insertion. We'll start to see Haglund's formation on the lateral aspect of the heel. The medial fibers of the Achilles are kind of slacking. They're not getting tugged on at all. So people will get lateral insertional Achilles tendonitis, Haglund's deformity, infracalcaneal fat pad irritation. These are things that are kind of normal with the C-quad, especially as they get to be in their 40s or 50s. So let's move on a little bit further onto the gait cycle. And what we're going to see now is, as we go into propulsion, let me go to the right foot. I think the shadowing is less. As we go into propulsion, we're going to start to notice that propulsion is off of the medial hallux and around the medial border of the first metatarsal head, because this person really is supinated. So they have a hard time. They have a hard time really getting weight down onto the first metatarsal head. Their weight is more lateral, and they only achieve medial loading in terminal propulsion when their heel comes up off the ground and they kind of collapse into that medial forefoot alignment. So let's watch this one more time. Not a lot going on. An out-toe gait pattern, tugging on the lateral Achilles insertion, lots of lateral weight-bearing pressure. But where's the compensation then? If the subtalar joint isn't pronating, how are we getting weight on the inside of the forefoot? It's coming from your hips. The lateral rotation of your hips allows you to kind of collapse into the medial forefoot. I do have a little bit of an exercise, like a lab section that I do to explain this a little bit better. I don't think we have time to do that tonight, but if anybody wants to email me, I can walk you through it and you can see. It really kind of drives home how the lateral hip rotation is necessary to be able to collapse over the medial arch, because the subtalar joint can't pronate, and you can't go around walking on the outsides of your feet all day long. You have to satisfy Newton's laws of gravity, and in order to get weight to the inside, we have to laterally rotate our hips. So therefore, the compensation is where the pain occurs. So C-quads often have hip bursitis, iliotibial band syndrome, piriformis syndrome, low back pain. Very common symptoms for a C-quad, because really all their compensation is coming proximal up the axial skeletal system. It's not happening at the foot until they get to be 40 or 50. Then we see fat pad atrophy, and we see some collapsing of the arches and plantar fascial strain and those kind of things. Let's go. Oh, wait, there's the callus pattern I was telling you before. In terminal propulsion, you're not propelling straight forward over your foot. You're propelling over the sides of medial aspect of your foot. So we're going to see a big pinch callus of the hallux, and you might see a little kind of crescent moon callus right here, but the skin under the first metatarsal head, it's kind of soft. It's not really encountering much pressure. So coming back to our quadricep poster that I was telling you about before, if you look at the quadricep poster, it will show you a picture of how the C-quad walks. It'll remind you of the three main characteristics of the gait cycle: core shock attenuation, restricted subtalar joint pronation, and propulsion is occurring off of the medial aspect of the hallux. It'll remind you the heel's inverted, that the forefoot is neutral, that there's a nice medium kind of arch. This is just another symbol here showing the heel's inverted to the ground. It'll show you, oh, I got to talk to you about this, the false toe sign. I'll come back to that in a minute. It'll remind you that the possible clinical symptoms are hip pain, low back pain, iliotibial band syndrome, retrocalcaneal bursitis or Haglund's deformity, medial pinch callus of the hallux. Let's talk a minute again. Let me go back to the false toe sign. Remember, I told you that a toe sign on a C-quad is neutral? It is. But when they're walking, you can easily think, oh, goodness, I think I see too many toes laterally. But you don't want to stand directly behind the person when they're walking. You need to kind of get into the frontal plane of one leg at a time, because this person walks like a duck. So if you're standing in the back of the treadmill right in the middle, you're going to think, because the hips are rotated out, that you see a positive toe sign on each side of the leg. That's a false toe sign. If you want to check the toe sign of the left leg, I'm going to need to come way over here to the right side of the treadmill and get behind the frontal plane of the left leg. Then I'm going to need to come over here to the left side of the treadmill to get into the frontal plane of the right leg. And if you do one leg at a time, then you'll notice that the toe sign is neutral. Don't confuse out toeing that's coming from the hips, lateral hip rotation, with an abducted forefoot alignment. That's motion of the forefoot in the transverse plane. We're going to see that in the E's and the F's, which we're not covering tonight, but I can teach you more about those. All right, so let's move on to the next slide and talk about some variations. The C-quad has a normal kind of normal to maybe subtly high arch foot when they're younger. They have that false toe sign. Looking from their back, their heels are inverted to the ground. We saw that earlier. But sometimes we're going to see what I call a super C. It's like the Superman of C-quads. And a Superman of C-quads still has a neutral forefoot. The forefoot's still, you know, perpendicular to the bisection of the heel. But sometimes if your heel's inverted, remember 4 to 5 degrees of heel inversion is good and okay. But 6, 7, 8, 9, that's a C-quad, not so bad. But once you get to like, oh, here's a C-quad that heel's inverted 10, 11, 12, 13 degrees. Now those C-quads are going to have more of a subtle cavus arch. It's not your Charcot-Marie tooth looking foot, but it's a pretty full arch. They'll start to have a higher instep, and you're going to start to see some toe climb, because if your heels are inverted to the ground, then your whole forefoot is elevated to the ground and you're wobbling, your body will wobble, so your toes will naturally grip at the ground to try and self-post medially. I call that self-posting. When the toes start to crunch down and try and grab the ground and stabilize. That's still, when you see this extreme cavus foot, you might think, oh, that must be an A-quad. Not necessarily. It could be, but you can tell the difference by looking at the callus pattern. If this is a super C, as opposed to being an A, then you're still going to see baby soft skin under the first metatarsal head, but you'll probably see even a bigger, thicker callus under the hallux. Hey, by the way, any of you podiatrists out there in podiatry world that treat diabetic patients, what do you think you're going to see here instead of a callus? Yeah, you're going to see a diabetic ulceration. The C-quads are 28% of the population. So the A's we'll get to, those are the 10 to 12% I talked about earlier. But C-quads, they're pretty common. 28% of the population, so 28% of your diabetic patients with neuropathy are going to end up with a hallux callus or hallux amputation. Hallux ulceration, I mean. Now, A quads, we're going to get to in a minute. We're going to see A quads are going to have a heavy callus sub first met, and we'll understand why in just a bit. So that's your C quad and your super C quad. Now let's talk about so what the heck is a super C? I just told you. The next thing is a C quad that might pronate a little bit. Most C quads either have a pretty normal looking arch or a subtly cavus foot or a subtly pronated foot. You can't defy aging. So over time, even a perfect arch is going to start to collapse from mileage on your feet. And remember, there are 4 feet in the quad group. When I do customs in my custom lab, I will be picking and differentiating exact foot type to exact foot type. But when I'm using our prefab quadricep system, which I'll tell you about more in a bit, quadricep system offers 1 color-coded orthotic for a group of 4 feet. So it's better than what you're going to see on the over-the-counter market, which is kind of most of the over-counter orthotics are the same orthotic for every foot, whether it's a high arch or a flat foot. Yeah, maybe they might add a met pad, or maybe they might have a full length or 3/4 length cover, but the C-Quad is like a professional version of a over-the-counter, a prefab orthotic. It's a medical grade prefab that you select and pick by foot type. So you can say, hey, I want a blue one on the left foot, but I need a yellow one on the other foot, and I want a met pad and a top cover, so you can customize them. But sometimes in this group of Cs, we're going to see the foot type C13. A C13 is the second most foot type in this blue group, and it means that there is a small but rigid forefoot varus. So sometimes we'll see a 1, 2, or 3 degree forefoot varus, but we'll see it's pretty darn rigid. So when I put the C-Quad, or often if you've ordered custom orthotics that didn't work for people, this is probably why, because C-Quads are common. And if you put just a 3/4 length basic foot orthotic under a patient and you don't have some forefoot posting on there, you're going to see what we call ramping, where the back half of the arch looks well supported, but we're starting to lose support at the distal end of the arch. So when you see that, you know you probably needed to post that up. So we have a modification that we'll do on our prefab system, or of course in my custom lab, I would do it. I would just add that from the get-go. But if I have an orthotic that's either already made or I'm going to use our quadricep system, I will often add some medial forefoot posting by using something soft like Poron and creating a varus metatarsal bar that's kind of wedged medial to lateral. Some feet are different. Some people have different feet left to right. I call that a foot disparity, and that can cause a functional leg length discrepancy and cause a lot of problems with the hip and the back. This kid that we're looking at here on the right, he has an E quad. He was congenitally 2 different foot types. He has an E quad on the right foot, so we see a moderately pronated arch. And if you were looking from the back, you'd see a positive toe sign. But the left was a C quad. Well, look over here on the right. That's his father. This speaks to genetics. His father, same thing. A right E quad, a left C quad. And look what's happening with dad. As you get to be a little bit older, gravity takes over. So the foot is getting just a little thicker. The arch is starting to come down a little bit of the intrinsic atrophy and clawing of the toes. The toes are starting to claw to try and restore that arch and hold it back up, because you can't defy age and you can't defy gravity. Hey, speaking here, I know it. So you want to be aware of the effects of time over force over time. All right, that's our C quad. So we're going to move now into the A quad, and the A quad is completely different, same but different. Okay, it's still a cavus foot, but now we don't have a neutral forefoot. Now we have, if I were to put the patient in subtalar neutral, I see there's a forefoot valgus where the forefoot is pronated or in a valgus alignment relative to the heel. So when you see that, then in gait, the first thing that's going to happen is the first metatarsal is going to hit the ground, and then the body's going to have to do something to get this lateral side of the foot down to the ground. So this is an inverted heel with the forefoot valgus. So remember before we talked about C-quads had to walk like a duck, John Wayne, 1 foot east, 1 foot west, to try and be able to pronate over the medial aspects of their arch. Well, this foot doesn't have to do that because the forefoot is in valgus. So that forefoot valgus kind of offsets the rear foot position, and it brings the feet back to a linear position. I love football. I'm a huge football fan. Philadelphia Eagles, Super Bowl champions. Go Eagles. I'm a very happy woman. So any Eagles fans out there, show me some hearts. So anyways, the forefoot valgus offsets that inverted heel. I'm not seeing any heart. Oh, there we go. Thank you. I see some hearts and a thumb up. So the feet on the A quad walks one step right in front of the other. So let's go ahead and take a look at that in just a minute. And then I'm going to come back to this. I'm going to go backwards for a little bit. Oops. I am going backwards. Hitting the wrong button. Hold on. I want to show you the A quad in motion before we start to go into these slides. This is what I'm talking about. A quads walk like they're on a tightrope, 1 foot right in front of the other. And the reason they're doing that is because, ooh, I hit the wrong button again. Boy, I'm gotta work on my mouse control. All right. So when you're watching an A quad walk, let's watch this right foot. You're going to see at heel strike, the heels really invert it. And watch as the forefoot comes down to the ground. You see the peekaboo toe? Remember I said A quads, top row, forefoot valgus draws your feet inward, and you see too much of the big toe medially. That's called a peekaboo toe. When you see a peekaboo toe or a peekaboo hallux, I call it, that means that you have a forefoot valgus. And so the forefoot valgus draws the foot inward into adduction. It draws the feet closer together, and we see this more linear gait pattern. Remember, the C quads walked really out toe. The A quads, they don't. That forefoot valgus kind of offsets it. The other thing you'll notice with a forefoot valgus is that, hold on. There it is, driving off that first metatarsal head because of the forefoot valgus. Let me see if I can show you this in swing phase. There, you see that alignment of the forefoot is in valgus. The first metatarsal head is typically what hits the ground pretty quickly. And we already have a very inverted heel. And so we're going to start to see early resupination and how that drives the force laterally. So we know there's going to be a lot of pressure, excuse me, under the sesamoids. And look at the peroneus longus. You see that peroneus longus tendon popping out? That can cause a snapping peroneal tendon. Excuse me 1 second. Snapping peroneal tendon, which can lead to a lot of lateral ankle pain. Sorry. Okay, back up. All right, so here's our forefoot valgus. So what happens when the forefoot valgus first comes down to the ground? It's going to hit early, and then the ground is going to start to drive the first ray dorsally. That can happen for about maybe 2 or 3 degrees or 2 or 3 millimeters of motion. So when the forefoot valgus hits the ground, you'll see it over here, 1, 2, 3. The first thing that happens is the first ray gets jammed dorsally. The next thing that's going to happen once that range of motion is used up, then the forefoot will start to be pushed by the ground into this supinatory twist, it's called. So the lateral part of the foot starts to get pulled downward, and that pulling downward, that's a normal motion of the foot. That's motion around the lateral mid-tarsal joint axis. And typically we have about 4 degrees or so of motion around the longitudinal axis. So this is telling me if we think about it mathematically, if the first ray can get pushed up 2 degrees, and then the long axis can supinate another 4 degrees, 6 degrees of motion can be absorbed by the foot. But if you have a patient that has a forefoot valgus that's 7 degrees or more, then you're going to start to see supination at the subtalar joint. Now, I know probably in school, early on, we were taught that forefoot valguses create subtalar joint supination. That's not necessarily true unless it's a pretty big forefoot valgus. And so what you'll see when you see those really big forefoot valguses, which by the way are our A quads, then we're going to start to see that when a patient moves from a neutral standing position to relaxed calcaneal stance and they have an A quad presentation, they're going to supinate at the subtalar joint. So let's see that. Let me see, where is that? I have that video here. Here we go. Let's listen to this video. I don't know if you're going to hear this video or not, but I'll walk you through it. There it is. This is a co-teacher of mine, Joe, telling this patient, go to neutral and then relax. There's neutral and there's relax. So what we see is when that person goes into their subtalar neutral position, they're struggling. They can't pronate. And you'll see these creases at the first metatarsal. They're having a hard time pushing through that forefoot valgus. But when you tell them to relax, what happens? And when they go into resting calcaneal stance, they supinate more. So this is a very not so common foot type. I mean, I would say 10 to 12% of the population is in the A quad, but only about 4% of that 10 to 12% is really going to have that excessive supination. Most of those people, I've learned from a lecture I heard in the UK, they think that most people with this severe cavus foot are actually on the spectrum of CMT, and that most of these people that have really, really cavus feet are probably in some level a low-grade CMT patient. So going back to this slide now, we see how are we going to manage that? This is a picture I found on the internet, and I liked it because it was a nice anterior view. Lateral posting is what we want, but on our quadricep, on the A quad quadricep, I like to incorporate a first ray cutout. Obviously, I think we should be offloading those sesamoids that carries too much pressure to begin with. So I don't like extending the posting under the first med head. I want to cut out for that. So that's the only difference I would make on that design. So we saw the gait video, and we know that the heel is really inverted. The forefoot's in valgus. Lots of lateral ankle sprains because there's too much supination. We saw that peroneal tendon popping out, so we know in fact, anytime you see somebody with peroneal tendon issues, pay attention. They probably have a cavus foot. And so you're going to want to have a nice orthotic design with all these nice features that have like we have in the quadricep, a lateral heel clip, a supported arch, lateral forefoot posting, first ray cutout. You also want to kind of incorporate a little bit of a heel lift on these orthotics because almost all of these severe A quads have forefoot equinus. Not the same as rear foot equinus, not something you can stretch out. It's not a tight Achilles. It's a structural positioning where the forefoot is plantigrade, plantaris to the rear foot. That can also lead to knee recurvatum. So when you have that really torque foot, we call it a torque foot, that causes the knees to move into hyperextension and creates much more sacral torsion, a lot of sacral problems, and actually a lot of cervical thoracic problems. Me being a former PT, I can tell you the sacrum and the atlanto-occipital joint of the neck, they mirror each other. Whatever one is doing, the other is mirroring. So people who have SI joint problems typically have headaches. They have neck-related issues. So the orthotic designs, again, all the features are relative to that particular foot type. This is just showing you, oh, here's that knee recurvatum picture. So this is an A quad. Look at that peroneal tendon popping out. causes the knees to go into hyperextension. Here's the forefoot equinus, so add a little heel lift to support that heel. Here's your first and fifth met calluses, clawing of the toes, and then because your rear foot is perpetually supinated, this is just a schematic showing you that that peroneal tendon is so taut that there's almost always a plantar flex first ray component of this forefoot valgus, because the peroneus longus is really just tugging and pulling at the base of that first metatarsal. Don't be shy in adding met pads. I like to add a met pad to help with that firing of that intrinsics. And this is more of an aging A-quad that we were talking about, the effects of aging. Even an A-quad will drop in arch height. So this, you can tell this person probably had a higher arch when they were younger because of their high instep. But as that arch collapses, those toes will start to fire, those intrinsics will start to fire to support it. This is also an article that I wrote on the Cavus foot type. It's on my website. If you want a copy of it, email me and I will get you a copy, or I'll send you the link to that webinar, to that article. It's pretty summarizes a lot of what we're talking about tonight. Shoes, really quickly. We know that there's going to be a tendency to roll laterally, so we need shoes that are going to support laterally and prevent this excessive supination. I don't like shoes that cut away in the waist. They're not I'm not a fan. So we need to see, we need a shoe that's a neutral cushion shoe that will help absorb shock, or shock. And if it's a heavier patient, maybe more of a neutral stability shoe, because we need a stable heel counter. We need an arch that's full through the middle, so we're not rolling over the side of that shoe. I particularly like shoes that flare out in the heel to give that heel some enhanced stability. They need to be deep and high to accommodate this high instep. And it's not a bad thing to have a forefoot rocker, which kudos to Brooks for the Brooks Ghost 2 Max, best shoe on the market. I'm going to give a shout out to that company for that. It's a saver for me and the patients that I treat. And I also really like the Saucony Echelon. These are my top 2 picks for the Cavus foot. Nikes, just say no. Just say no to the Nike shoe. These really curvy, cut-in waist, when the shoes are very narrow on the instep, those Cavus feet are going to roll right over those, especially if they're curve lasted, like a lot of track shoes are. Those are going to be perpetual ankle fractures, high ankle sprains, because as the shoe is rolling in and narrow at the waist. You want a fuller midfoot and a straighter last, so that there's more support on the lateral side of the foot where they need it. In really severe cases, I've seen some really bad ones, we may need to be thinking AFOs or shoe modifications, lateral wedging, lateral flares, lateral buttress. Those are more severe, like your CMT type cases. Shoe modifications can help. So this is again, just the quick summary. That's your A-quad, or C-quad, sorry, toe out walker. And then your A-quad is your more linear, 1 foot in front of the other walker with a bit higher arch. So getting back to what we do at Nolaro 24 is the company. Quadricep and Little Steps are our products. This is what we call a quadricep fit kit that has one of each of the color-coded orthotics in every single size. It's a fitting system. We do offer kind of steep discounts on a starter kit. We call it a starter kit, so that you have all the different color-coded orthotics in every single size, so that you can fit your patients easily. If you want to learn more about using the quadricep system, which is a good revenue, it's a practice management meeting, so it's a good revenue generating. Your cost on a pair of quadriceps is probably about $40 to $50, depending on your volume, and they resell for $175 to $225. So there's good margin in the quadriceps. If you want to learn more about it, call me, email me, and we can talk more about it and get you started with that. But more importantly, learn more. We have a biomechanics masterclass that we teach every year, and it is right around the corner. And I really, really encourage you to sign up. The next class is in Connecticut at the Bradley Airport, right at the Sheridan Airport, right at Bradley. So you'll never leave the airport. It's kind of weird. You just kind of stay there for the whole weekend and talk about feet. The conference is May 2nd to 2nd and 3rd. This is a QR code if you want to scan it, which will take you right to my website for more information on the class. And I also want to offer you some specials today. This is my special. If any of you are interested, I'd love to see you get started with our quadricep fitting kit. So I'm going to give you $200 off our discounted kit price if you call or set up a meeting with me sometime this week. You don't have to have the meeting this week, but if you call and arrange the meeting, I'm still going to give you the $200 off. And then 25% off of masterclass signups for anybody who signs up before this Friday. Okay, we have a small room block at the airport. They allow us to have 25 rooms, and they are filling up. So we'd like to get that capped off and get a few extra people in there before we run out of that room block. So here's your QR code to sign up for the class. It's cheap to begin with. It's only $250, but I'm going to give you another 25% off if you sign up by Friday. In closing, take a look at these pictures here. Pictures I took from the internet. And look what you've learned already. This guy, you know he's an A-quad because he's wearing a yellow jacket. So that makes it easy. Just kidding. You can see the Cavus feet here. You can see anybody who stands like this. Look at this guy standing here with his feet pointing east and west. That's a John Wayne Walker. There's another John Wayne Walker. You know, here's another John Wayne Walker. So you're going to start to know by looking at the people standing in the grocery store what kind of foot type they have. So that's it. I think that's the end of my presentation. I'll leave this up while we're doing the Q&A so people can scan that QR code and sign up for the masterclass. I'd love to have you there. It is really kind of like a culty kind of weekend where a bunch of people are really just interested in feet and biomechanics get together, and I'm sure you'll walk away with a really good understanding of foot typing.
Awesome. Thank you very much, Roberta. That was amazing. I mean, you, you could tell you're passionate about the different types of feet and that you've dealt with it,
It's weird,
for a long
isn't
time. Yeah. So one of the questions that came in was related to one of your slides, and it was when you were switching back and forth and you were going backwards and forwards. The question is this picture in weight bearing or non? And I tried to catch what else was on the slide, but I don't remember. Maybe you remember.
I probably could tell you without going back. It's all weight bearing. Non-weight bearing is irrelevant. It's sort of funny because people will say, well, Roberta, if you think you can assess everything in weight bearing, do you bother to take like subtalar neutral measurements and all that? And I say I do on every single patient. And people will say, well, why do you do that if you think it's irrelevant? And I say, it's like smoking cigarettes. I've been doing it for 30 years and I can't quit. You know, so people come in, insurance companies love you to have numbers in your chart, objective measurable data. So you're going to take your subtalar neutral measurements and stuff, but nobody functions near subtalar neutral. It's more important. I can teach a practitioner to be 100 times more reliable in their assessment by watching a person in standing and in gait in their maximally pronated position is much more inter-rater reliable, and you're going to get much better orthotic outcomes when you learn to view that way. But sure, take the measurements. Looks good to have measurements in your chart.
Awesome. So we did get a comment from one of the attendees saying to share the recording with them. Obviously, we're going to send out this recording to everybody who's online, but early in the webinar, you mentioned a recorded training. Was that the foot typing training?
So on my website, which is the end of my email here, nolaro24.com, you can go to our education page. I think one of everybody thinks of us as the little steps and the quadricep people, but really we're the education people. Go to our educational page. You're going to be kind of wowed because we have about 20 or 30 recorded webinars on different topics. We have a recorded webinar on the 4 steps to foot typing that I really flew through, so I encourage people to look into that one. Just know too also that there are fees for our webinars, but they are waived for people that use our products. You know, if you have our starter kit, those webinars are free. So don't pay for them if you're a starter. If you own a fit kit, just contact me. I'll get you a free pass. So there's webinars on the 4 steps to foot typing. There's webinars on all 6 quads. You know, there's webinars on pediatrics. There's a ton of stuff out there, and all of it is covered in the masterclass. I really love it when people start with the quadristep system, like now would be the perfect time, and you have it in your hand and you played around with a little bit and then come to the masterclass. That's ideal, because the masterclass, when you come to the masterclass, you don't want to be like the deer in the headlight. You know, it's good if you already kind of have some fundamentals and you understand it. And then you can, you know, and then you can have at it and really take home more advanced knowledge when you come to the class.
All right, so the biomechanical masterclass is coming up in May, and it's in Connecticut. Have you ever had them outside of Connecticut? Like, one of the questions is, do you have them in Florida?
We have, but we're probably not going to do that so much now because it's hard. It's a lot of equipment that we have to haul with us and set up, and we need a whole entourage of staff to make this class work and make it a good experience. Also, because a lot of the people who come want to come to my lab when they're done. A lot of people will stay an extra day and come and visit my biomechanics lab, and we go do a tour of the orthotic fabrication facility, and we do some private one-on-one stuff with them. So if anybody is interested in attending and doing that, let me know. I do have a couple students coming. I have a student coming in from Korea that's going to be spending a couple days, 3 days with me this month, coming to the master class and spending another 2 days after that.
Do you guys offer credits for the master class? Because that's one of the questions down here in the
I would
list.
love to offer master. I offer master class. I offer continuing education for the Physical Therapy Association, orthotists and prosthetists and C.Peds can have CMEs. The APPMA is rigid. They won't let anything that they perceive as product promoting, like unless it's offered by an organization like the APMA, they will not give us CMEs. I'm so sorry. It isn't, but I will tell you, it's just $250, and with the discount, it's only, I think, $185. It will be you will walk away saying, I've learned more in these 2 days than I did in my entire podiatry training. I've heard that so many times. And by the way, it's not just Lewis and I lecturing. Patrick DeHeer, who many of you might know and appreciate as a genius in your field. He will be there speaking on equinus conditions that affect the foot. And he's a pretty darn good lecturer.
Let's see here. A couple comments about people getting their flights already. So that's awesome. Thank you. Great info as always. You're amazing. Here's a question. When applying a post, how do you determine if it should be intrinsic or extrinsic? And please differentiate both.
I love that question. I can do that. So I like to think about it as intrinsic is bringing the ground up to the foot. So if your heel is in that supinated or stuck position, I will sometimes I like to put heel posts on my orthotics. Let me go back to a picture of one of the orthotics, any one of them. So this post on the rear foot, I like to call it a balancing post, not to be confused with what some people think of as posting, is putting a varus wedge under the heel. If I put a varus wedge under this heel, I would invert that heel more, and I don't want to do that. So when you're intentionally inverting the heel, or the forefoot for that matter, when you're intentionally imparting an angular change, that's extrinsic posting. But if you're just bringing the ground up to meet the foot, that's intrinsic posting. So this heel is already inverted. And think about that. Remember I was talking about the infracalcaneal fat pad. When you're young, the infracalcaneal fat pad migrates medially and it fills in that space between the medial calcaneal condyle and the ground. It's created its own intrinsic posting. But over time, nature takes that away with mileage and erosion. That fat pad erodes, and now we start to see what I call a collapsing cavus foot, because now we don't have our own natural intrinsic posting, so the arch collapses. So when you're putting a heel post on an orthotic, just to bring it up to where it's supposed to be, that's intrinsic. Beyond that is extrinsic.
All right. Why don't you implement top covers on your orthotic devices?
Well, funny you should ask that. Hold on. We don't have them on these orthotics because they're a professional version orthotic. So I want you to feel comfortable ordering. We can put top covers on any of them. You can order them with top covers. We'll put them on. You'll get them. They'll come with a cover. But sometimes people will want an A quad with a Met pad on the left foot and a C quad with added varus posting or a relief for the fifth metatarsal head. So when you order our quadriceps, feel free to order them a la carte, like you would a custom orthotic. We will assemble them. So people have the misconception that the quadriceps are a replacement for like a super feet or a power step. They're not. They're a replacement for custom. And why would I want to do that? I own a custom orthotic laboratory. What am I, crazy? No, because I had a patient today and he really was messed up. I have to say, this guy is messed up, but he cannot afford a custom orthotic. But guess what? I can fix them. I can take out my quadriceps and I can customize them, covers, heel lifts, lateral wedging, medial wedging. I can do anything to the quadriceps I want, and I can deliver him a custom orthotic, and his out-of-pocket expense will be about $225 to $250, as opposed to we charge $650 for customs. So gauge your quadriceps less than what you pay for customs, about half of what you pay for customs is usually what I'm looking for. And your cost is going to be $40 plus, $20, $30 in modifications. So you're still making the same margin that you would make on a custom orthotic. You're making the patient happy. And guess what? You don't have to bill the insurance company. What's better than that? It's a cash paying product. But since you also asked, I have a new product coming out, and you'll all probably get an email on this. This is called the Tri-Step. This is the first of 3 models. And guess what? It's for the AC quad. So there's going to be 3 models, one for the AC quad, one for a moderately pronated foot, and one for a foot type that needs medial forefoot posting. So those are in production now, but we're going to be launching the release of the Tri-Step. The first of the 3 models will be coming out sometime this month. And I'm real excited about it because I have this foot type and I've been wearing these for about 3 months and they're pretty nice. I really like them. They meet up pretty well with my my prefabs and my customs. So I think people are gonna, they won't last as long. The quadriceps will last your patient 3 to 5 years. That's not much different than a custom orthotic. So the quadriceps are built to last, where the triceps are more like a prefab and they probably need to be replaced at least once every 6 months to a year, depending on the size of the patient.
This one says, correct me if I'm wrong, a post is placed to stop the compensation force.
That's correct.
Okay.
That is correct.
Are quadriceps available in most adult sizes?
Yes, quadriceps run, some of our quadriceps run in more sizes than others for reasons that we don't see a lot of really big A quads. I see like up to size 12 or 13. I don't see a lot of size 14 A quads. They probably collapse before they get, because of the length of the arch. But most of them come in at least 5 sizes that will range from like a men's size 5 to like a men's size 13. We do have the C's and the D's actually go up larger than that. They'll go up to like a 13 to 14. And some of the E's will go down to a men's size 4. And we also scale them a lot. Like a lot of our clients will call me and say, hey, I have a woman who's an adult, but she's only wearing a size 3.5 or 4 shoe. So we'll take our smallest quadristep and they'll send us a foot tracing in standing, and we'll scale it to that. With it, all of the orthotics, that's another thing that makes them custom like. The material is grindable. So I can grind the length, the width, the depth. It's a really nice material. If you're hands-on, you have your own sanding grinders, it's a wonderful material to work with. It kind of gums up like polypropylene, so it's easy to work with.
I think this question is a great one to end on because it kind of tells a little bit of your story. Where does the name quadristep come from?
Well, quadristep is a better name. I got a two-part answer to that. Number one, the name Nolaro, which is the name of the company, is Roberta Nole, top billing right here, combined with Louis DeCaro. So Nole and DeCaro make Nolaro, and there's 24 feet. So that's the more interesting story. But the quadristep came about actually when I invented the quadristep system. I called it the quadristep because there's 4 feet in every group. But then I connected with a distributor in the UK, and he pointed out that the better concept of that is there's 4 steps to foot typing. You know, arch height, toe sign, gait, and then the calluses. So the 4 steps to foot typing is one of the reasons of the quadristep name, and that there's 4 feet in every quad. So it's not like you're an A. Remember, there's 4 A's, there's 4 C's, there's 4 E's, and that's what makes them, you know, what gives us the ability to customize them and make them even better or as close to custom as possible.
Awesome. Well, you have answered every single question, and we've ended right about where we need to be. So any last comments from you? I know we've got a couple bonuses we're going to be pushing out this week. So the 25% off the masterclass if you register by the end of this week, and the training webinar for the 4-step foot typing, and then the starter kit for $200 off. So we are going to definitely get those offers out to everybody. What else? Anything else going on?
I think the main thing is connect with me. I love to hear people. I love to hear your feedback. I love to hear more about what you want to learn about. I mean, teaching it, like I said, Louis and I, we love to teach, you know, and we sell products. Yeah, we sell products, but we still have day jobs. We still see patients. We love treating patients. It's like, I tell people I've been doing this now for over 30 years. In fact, last year was my 30-year anniversary. And I'm still in, every time I go into a room, I'm super Roberta, I'm like super enthusiastic. And it's like a hobby. I love this. This is my hobby, not my job. And I hope that all of you feel the same way, you know, and if you don't, then you need to learn the love of biomechanics because it's so much easier than surgery.
Yeah, that's one of the sayings, you know, if you love what you do, you never have to work a day in your life.
Yeah.
Yeah, very true.
Yep.
All right. Well, this recording will be up on the podiatrymeetings.com archive page by the end of the week. And we'll share it with the Nolaro 24 team so they can have it on their end as well. And then if you have any questions, reach out to Roberta and we will see you at the next webinar.
Thanks. Thanks for having me.
All right. Thanks
All
for coming. We'll talk to y'all soon.
Bye-bye.
Good night.